Welcome to the Thought Diaries, a podcast dedicated to mental health, neuroscience and trauma. I'm your host, Roxanne, owner of Helix Trauma Training and founder of Trauma Healing UK. Hi everyone, this morning I'm joined by Isabel from Moving Minds. Isabel, I was wondering if you can maybe just tell us a bit about what you do.
Yeah, absolutely. Hello, I'm Isabel. As Roxanne said, I'm from Moving Minds. I work with something called TMS. TMS stands for Transcranial Magnetic Stimulation. And essentially it's a magnet that creates a magnetic field around the magnet and sends a magnetic pulse to a targeted area of the brain. So it's held over the head. And you can use it to either increase the activity of the cells and the neurons or decrease the activity of the cells and the neurons. So we have a mental health company that's kind of our main focus of what we use at Moving Minds. But we do some kind of aftercare things as well, using different integrative therapies and kind of a focus on whole well-being and holistic health.
So TMS is quite a new thing.
Yes.
As far as I'm aware. What would you say the last 20 years?
But
yeah,
so
even I think because it's only been maybe last year that I've heard of TMS, because you've heard of ECT. That was always,
yes.
Yes. When I think of TMS, I closely link it to ECT, even though it is different. But in terms of the progress of that technology, and ECT's goes back way back.
Way back.
Way back. So yeah, how was it developed? Why was it developed? Do you know, Isabel?
Yeah, so it was first used actually to map out the brain. So they kind of used it to stimulate certain areas of the brain and see what happened. Was something else a behavior or a response elicited as a result of the stimulus? The main one they did first of all was they targeted the motor area. And they found that when they targeted the motor area or a specific part of the motor area in the brain, when they stimulated that, they caused twitches in the hand muscles. So then they could say, oh, actually, if we can use this to get a response from the muscles, then we must be able to use it to get a response in other functions of the brain. But that was the first TMS device as we know it now was developed by someone called Simon Barker. I think that was in 85, so not that long ago. And it was originally used, for that kind of functionality, testing functionality and mapping out the brain. And then it was slowly used and developed to be used not only for psychiatric conditions, but also neurological ones. Things like strokes as well. It's now beginning to be used for. But it came in the UK as an approved treatment for major depressive disorder, so depression, in 2015. But before that, in 2008, it was in the United States. So we're a few years behind the States. But
am I correct in thinking that it's only really been England that's adopted it as a treatment? In Scotland are still a bit
behind. So in England, the first NHS trust to pick it up was Northampton. That's now developed, and there's a few more that have picked it up in the NHS, but there's many more private clinics across England. In Scotland, there's just 2 private clinics. One is our one, Moving Minds, in Glasgow, and the other one is in Edinburgh. At this stage, there's no NHS. There's no NHS for it in Scotland yet, but that's something that we're hoping to kind of work towards and help get it on the NHS, because it's amazing treatment that will help many, many people who need it.
And I was looking at research the other day, and the studies are showing it's effective, especially for if we kind of focus on depression, because that's what it's approved for at the moment in this country. And if anybody's ever, I think that it's important for us to differentiate between like really chronic long-term depression, which is, if you've experienced that, or if anybody's experienced that, I guess it's people have lived 30, 40 years
Yeah.
depressed. They don't know
Yeah.
anything else.
Hmm.
Uh, and medications haven't worked, all sorts of treatments haven't worked. Because
Yeah.
I always think, I'm going back to ECT slightly, but
Hmm.
uh, there's some argument within the mental health about, and I'm doing myself a job here as well, that if you go to therapy or you change your lifestyle or you do this and you do that, then you'll get better. You're just not trying hard enough. But I
Yeah.
don't think people realize the debilitating
Absolutely.
feel the symptom of being like that for 40 years, which is
Yeah.
why, like, again, ECT has its controversies, but at the end of the day, if something's going to work, and that's why I think
Yeah.
TMS is great, because
Yeah.
it's a new treatment that everything else has failed. It's not
Yeah.
in this person's head. No one chooses
Absolutely.
to live for 40 years depressed.
Yeah. It targets it in a very biological way, and
Hmm.
as I said, it kind of goes, well, it does, it goes straight to the network that we target for depression.
Yeah,
And yeah, it is recommended for those who are severely depressed and, as you say, have had it for many, many years. And
yeah,
yeah, whilst, as you say, the kind of lifestyle factors and the therapies can help people who
mhm,
have more kind of mild or moderate depression,
yeah,
they're still able to put those practices and techniques and skills that the therapist is giving them into practice. But for
yes,
those people who've had it for many years, they
yeah,
simply can't, their brain is not functioning at the same level. They
yeah,
simply can't, no matter how much they want to,
hmm,
they won't be able to put those into place unless something else
yeah.
is done before.
Definitely. And that's why I think we use the term depression both in the mental health industry and socially, culturally. But I
Hmm.
think I would like to see in 20 years' time for depression to be broken up. I know it is kind of broken up
Yeah.
within the DSM, but more into, because some people have got genetic
Hmm.
predispositions
Yeah.
to depression. They're
Hmm.
born with structural differences that
Yeah.
cannot be overcome simply by therapy. Those that have different types of depression, yeah, I mean, obviously I'm a therapist, I'm going to advocate it, but it's so different in individuals, and that's why I think so many, and I don't know what your thoughts are on this, Isabel, why so many antidepressants do not work, because it's not targeting the specific kind of cause and why that person's depressed, in terms of whether it's environmental stress, structural, genetics.
Definitely. It's, I think with, yeah, and antidepressants are kind of just given quite quickly at the moment, I think, and
Yeah,
maybe for the last few years, they're just kind of given to anyone who presents to whoever the treating clinician is with symptoms of depression, but those symptoms are not broken down and looked at.
yeah,
And there's no kind of individual treatment for them where it's saying, okay, well, you have these symptoms,
yeah,
these activities or this therapy will probably be better for you, or actually these antidepressants target specifically this, so this will work
yeah.
for you. Definitely, it's all grouped together.
Yeah, and I mean, antidepressants do save people's lives. There's no denying that it does make a difference to some
Hmm.
people. But study after study after study is saying that antidepressants as a whole aren't effective. But as we've just said, it's because they're not saying, right, this is the type of people who are more likely to have structural changes that are more likely antidepressants to work, or whether it's environment, however you want to class it.
Hmm.
And what I think is wrong within the, I guess, mental health consultations and stuff that people are getting, is that it's never a constant, it never appears to be a constant conversation.
Hmm.
So it's not, right, let's try this, how did that impact you? Because I think only
Yeah.
through that can we really understand depression. And I don't think we've even touched, I think we're much better now, but I think
Hmm.
from a practice point of view of how we operate mental health services and therapies in
Yeah.
this country, I think from that point of view, we're nowhere near
No,
where we need to
I
be.
I don't think so either. It's kind of, at the moment, everyone is treated, and it's because, to be fair, a lot of it is the lack of funding, and the psychiatrists in the NHS and the psychologists as well. I think a lot of them is it a time constraint? I don't know. I now haven't worked in the NHS for many years, but I think they probably have, their own kind of barriers that are preventing them from working with patients in the way that they want to work with them. But definitely, I think that there needs to be a change within society at which not only are we approaching mental health and particularly depression, but the way that it's treated as well and managed, because that's the thing as well, it's not everyone will need a treatment. A treatment is a biological, exactly that treatment, it's medical, and that is for those who are more severely depressed or, as we say, have had it for a long period of time. And I think it can be easy for people to think, oh, I need a treatment for this, and not necessarily thinking about the other things that could help them or that they could be doing. And that's because, as you say, as society, we talk about it in a very specific way, and there's we don't sort of cater for or discuss how it might be different for everyone, and everyone has these different experiences and throughout their whole life as well. Because for you, obviously, with trauma, a lot of it's developed from, or it can be developed from a young age, and that's the same with depression. You're much more likely to you're predisposed to depression if you've had childhood trauma, and the same with like addiction and all of these things as well. So there's so many different experiences that we have. We all live completely different lives. So of course some of us are going to be affected more, and some things are going to help us more. It's very individual.
Definitely. And I think I'd quite like to see in the NHS more a tier kind of, because you have, as you say, psychiatrists are under a lot of pressure, but you've got your kind of general psychiatrists, and I know they do have like divisions like neuropsychiatry and stuff like that, but I'd like to see more referral to more like niche, so to TMS, to trauma. And almost the psychiatrist to be more like a GP for the illness, because that way that's going to help time management as well. It doesn't help finances, but that's a different issue. But it certainly helps, because if a psychiatrist is only spending 10-20 minutes with you anyway, then you'd be better going and spend, and over the long term it would actually save the NHS a lot of money, I think.
Sure. Absolutely. And it's the same with TMS. Like I get asked so many times, why hasn't the NHS picked it up? Like there must be a reason why. And I mean, all the evidence is that. There's evidence that it works. We know that it's effective. The only thing I can think of, and that from speaking to other people I know who work within the NHS as psychiatrists, it's that they don't want to spend or pay the initial upfront cost. Well, if you pay the initial cost, the rest of the running costs are not that high. Once you have your staff, you're paying your staff, fair enough. But once you've got the machine and you've had the initial training, that's it. It will run itself. You just need, the practitioner, or some people now I think have nurses as well that do the TMS, but that's all you need. Your running cost is then the person that you're employing.
I know, and if you're thinking about someone who has been depressed over 40 years, the impact of, they're still going to a psychiatrist regularly, and they're not getting anywhere really. They've been on medication for 40 years, or different medication, constantly changing. This treatment, if it has, I don't know how, I think I read one study where there was a follow-up over a year and it was still effective, but I think I don't know if there was regular treatments in between that. You might be able to advise on that. But anyway, if it's just this works, this will, even if it was a year, this will help you for a year, and then you'll come back for your other treatment. That's still effective. And the social costs, the social benefits in terms of saving money as well, because these people can go to work. If you've got major depression for 40 years, chances are that you can barely pull yourself out of bed some days.
Definitely. And that's from my experience with TMS and the patients we've seen. Of course, there are some that are kind of, as we would call, moderate. So for them, it won't feel moderate, but they're able to function. But yeah, the people who have had it for many, many years, that is it. literally the only time they're coming out of bed is to come to the clinic.
Yeah.
And that's it, because they just can't function in any way at all. So it is, yeah, there's definitely room for it for those people. And it will help them for sure.
Yeah, I experience the kind of same frustration, because often the first response when trauma is to give CBT.
Yes.
Which there is all different types of CBT, and there is trauma informed, but the one tend to be in the NHS are the 6 to 12 weeks, very structured, practical CBT. Go and do these exercises, come back, which just is like, when you understand how trauma impacts when you really understand the neuroscience, then you just think, why would the prefrontal cortex isn't working? But you're giving people, I guess, exercises to engage.
It's the same in a way for depression. I was talking to a patient last week and her family about their experience, and this is a patient who's had severe depression for many years, over 20 years, and her mental health team were only trying to do the CBT with her and implement different goal setting strategies. And as we've been saying, that will work for some people. But when you have severe depression for this many years, those strategies, you need to look at helping them in a different way. If that person's been coming to therapy with you for however many years, why are you still trying to implement the exact same CBT approach that you've been doing before? And the worst part was that mental health nurse just then dropped that patient off her case.
Really?
Because she said to her, you're not doing the exercises that I'm giving you. So I can't help you. So we're not taking you on anymore. It's like, well, that's not their fault that they can't do the exercises. That's their brain.
I find the same. I have a lot of clients who have been dropped by their mental health care because they're just seen as untreatable. But it comes back again, that prefrontal cortex. Both depression and trauma, they do not work effectively. The longer it goes on, the more damage, the more difficult it is to engage. And I always think it's a bit like, your example is a bit like going to physio. I don't know if you've ever been to a physio, Isabel, and I've went and they give me exercises, and I'm I do it probably through laziness rather than, so it is maybe not the same example, but if you don't do the specific exercises on the bit of paper that I could get online anyway, then they're like, oh well, we can't help you. But what I'm looking for when I've ever been to a physio is more like someone to sit down and talk me through and really like engage and give me in that hour, whatever, something that's going to help.
Absolutely, and helps you long term. Because some of the strategies are, and and I do it as well for Moving Minds. I do like social media posts as well that just focus on like mood boosting tips and stuff like that. So kind of low level things that even for anyone who's quite healthy at the moment to do will help them. But there's I think I've kind of lost my trail of thought, but there's definitely different ways to approach it for different people.
And I think having all these general low level stuff as well is still great because it'll still help someone. So the mood boosting stuff, and you're just trying to reach, you try to come at it from different directions to reach someone and give them that help that they need. And because they're so individual, one thing might work from one person and one thing might not. And I think that it's all great. What I always like to put an emphasis on is like, it's okay if it doesn't work. Because I know from the trauma world, and you might experience that from the working with people with severe depression, is that there's a lot of shame if they can't do it. You've given me this, why am I not, but why can't I do this? There must be something wrong with me. I've lived like this my entire life, and it's incredibly sad and devastating.
Absolutely. I think for depression, they've then been running negative patterns and negative thoughts for so long, and the blame will be put on them. They by themselves, by good therapists or people that work with them, you don't of course put the blame on them, you do anything but that. But yeah, for them it will be seen as a personal failure, although of course it's nothing to do with them. You know, it's nothing they've done.
No.
But they will absolutely see it as that, and that will just exacerbate what they're feeling, and
Exactly.
they'll just think, yeah, that, well, this is what I've been saying has been true for the last however many years.
Yes.
Just
And
reinforces it for them.
then they'll just give up, as you would, you would
As
naturally.
back to the mental health team and nurses that drop their clients. Well, you're
Yeah.
now just reinforcing to them that they're the problem.
Yeah.
They're not the problem.
Exactly.
You're the
No.
problem.
Exactly, totally. And you know what I love most about this job is if you approach it from a really like a curiosity point of view of like as a challenge, right? So you've got let's work together, let's find out, let's try everything that we can
Absolutely.
until we get something that
We
works
will
for
get you
you.
better. Yeah, that's
Exactly.
it. It's
And
just
I do
finding the right thing for you.
exactly. And I mean I've had some really I've had clients who have been in therapy for 20, 30 years and not had a breakthrough, and then just applying different things until you get something. And that is a breakthrough. I mean, with a lot of these clients, yes, it's not the same as, as you say, it's a treatment. It's not the same as they'll go on and live their life as if they never had depression or they never had trauma or that they were completely 100% symptom free. It is a lifelong thing. I think it's always about being realistic, but it's about managing your symptoms to a level where you can go out and enjoy your life.
Yes. Yeah, you'll have to work at it constantly and consistently, as we all do with other areas of well-being.
Exactly.
It's constantly learning and pushing and developing. But I think probably something else from the people who have more sort of long-term and severe depression, it may be the same with trauma, I'm not sure, but they can find it more difficult to notice when they're improving and notice the changes. So that's when you have to then start implementing other strategies and kind of showing them and telling them where they were at the start and different things like that to really get them to recognize, actually, you know, you are improving, you are doing a bit better for X and X reason. But that's, for a lot of them, that's their identity then, isn't it? You know, and you'll see it in trauma. I think it's quite strong with trauma survivors as well, as then that is their identity, that's part of them, that's who they are. And that can be one of the difficult things to shape. But once you do, I think that has a really big impact once you can move on the identity stuff.
I mean, identity is probably the core bit of my work, especially with earlier traumas, because they've never really had a chance to form an identity, which impacts them neurologically, but in just an overall sense as well, because I guess their understanding of the world, if you've been sexually abused as a child, doesn't kind of fit into what you grow up in, your culture and your society, and trying to put those two together.
Definitely. You've got a totally different blueprint and map for the world, don't you?
Exactly.
To everyone else.
And then change, that's why people don't notice change, is because change is terrifying for trauma survivors, because as much as it's terrifying living with that identity, it's still that, is this going to be worse? That fear of unknown. Who actually am I? Am I a good person? Am I a bad person? If I change, am I going to become worse? So it's a huge thing, and it's great when you start to see someone create themselves an identity built on the foundation of who they are is underneath it all, and start to become themselves. And once you start to get that and you work through all the neurological and the trauma stuff, CBT can be really effective then, because it's right, this is my life now, what the hell do I do with it? And then you can use CBT strategies to go, right, well, let's set goals.
That's it.
But it can't, in my opinion anyway, it just doesn't come first.
I agree. I completely agree. And when we use TMS, that's it, we go straight for the kind of neurological side of it, the neuroscience side. We affect how the neurons in your brain are working as a way that's beneficial for you. And once they're firing more and they're firing as they should be, then you can start to implement the other strategies. And we do suggest CBT for people who are then in remission. And we say this will likely stop you from relapsing. That's very good evidence that it will stop you from relapsing. And it's a great tool to use, and it does work for those situations for sure. But definitely when you're looking at the more kind of severe stuff, there's definitely other methods. You have to kind of target a bit more deeply into the actual brain, don't you, in the biological structures.
But I think I do find it really interesting, and as we spoke about before, Isabel, and I've mentioned on other podcasts, is I am dead keen on neuroscience. Like, it just fascinates me because it just allows you to build up a really good picture of human beings. And I know for some people it's a wee bit too sciencey, and it could be a wee bit reductionist. Is that the right word? In terms of understanding human beings. But I don't think, I think you need it because it gives you so much information.
Definitely. And I think if used in the right way, it can help people to understand, again, kind of going back to what we were saying about people feel like it's them. It's not you, it's the way that your brain is currently and the way it's currently functioning. And as I say, there will be things once you're in a kind of better place that you can do that will help that functionality as well and boost it back up. But there's the structures you can't affect when you're so severely depressed or in that kind of childhood trauma state.
And my message, and I think I've said this plenty of times before as well, is for people to try different things, whether it's trauma, whether it's major depression, to explore. And there's so many options out there, and don't see like TMS as some scary technological type thing. It clearly has shown to be effective, and if it doesn't, it's shown to help a lot of people. But if it doesn't, there's other options out there as well.
I think that's it. It's increasing awareness of what the other, again at this stage, treatments are, because there are other ones, and there's many more developing at the moment, which I'm hoping to kind of look into a bit more in the coming weeks and do some blogs and things like that on. But there's so many things being researched that will help those people that other things haven't helped.
And I think getting a clinician or a therapist or whatever sort of area you go to get help, that they're knowledgeable and that they're supportive as well.
Absolutely.
That they don't pressure you into, you need to be doing this and you need to be doing, you need trauma therapy or you need TMS. It's about, well, these are the options, are really effective. Let's have a conversation about it and see how it might affect you.
And certainly there's also preliminary evidence coming in, which I'm sure there'll be more studies in the next few years, but saying that actually if you use, and it's similar with like medication, if medication works for you and use it with therapy, you may get a better response. The same as with TMS. So for PTSD, for example, you can use different paradigms that will boost its effectiveness and your responsiveness to it. And it's the same for depression. So we do different things with people. Some of it will involve goal setting, but again, it's different for different people. It's what's going to work for them. But definitely there's strategies and different things being introduced that will just help the process even more. It's not just come and have TMS or come and have this type of therapy like it used to be counselling. Everyone would go for counselling. It's like, well, no, it might help you, but there's other things that will also help you that we should also use. It's about using all these different things to really maximise how much you can help someone and help them the best way that you can.
I'm particularly interested in the moment, and it's not legal in this country as such yet, but hallucinogenics for PTSD. I think that's probably a whole conversation, because obviously that's activating neurons in the brain as well.
Exactly. Yes, it lights up specific networks similar to other things. But definitely. I've noticed there's been a lot of that work coming out in the last 5 years, and I'm also incredibly interested in it. And I do think it will happen over here. I think there might be some work in King's College at the moment happening. I might be wrong, but definitely in London.
I think
I
you're
think
right.
they're doing quite a
Yeah.
lot of studies on it.
Yeah.
But I always find this funny because do you remember, it must have been about 10 years ago, maybe more, I'm not sure. And there was that Professor Nutt who was, what did he come out and say? He said something about drugs. It may have been recreational drugs, but it may have also been drugs that were used to help mental health conditions. But he was basically saying that they could be good for you if used in the right way, and they could help your mental health and well-being. And everyone completely shunned him. He lost his job. He was like publicly shamed, basically, and told, basically they said that he was promoting drugs and all of this kind of stuff, which he wasn't doing at all.
Yeah.
Now, like however many years later it is, he's very well respected, and people have gone back and said, actually, you are right. And they're looking at all these drugs that he was talking about helping.
Yeah.
And I think about that all the time. I have a couple of books at the moment that have his name on, and he's publishing loads more research. And I just think, gosh, I remember that. And I wish I could remember exactly the details of it. But I do remember his name, Professor Nutt, N-U-T-T. And yeah, being a whole big thing in the media. And now he's like doing all these mad things and people really respect him for it. But it's all along the same line.
Yeah, exactly. It's just that cultural thing on hallucinogenics, drugs.
Yeah.
It's ingrained into us. It's a bad thing. And but I mean, it makes, when it comes to PTSD, if you can activate certain, if you really just want to reconnect the brain, and that alongside therapy is then you're cognitively restructuring. I mean, that's what I do with therapy.
Yeah,
I try
exactly.
to reduce the threat response in the brain to then activate all the other parts. My job would be so much easier if there was a drug that did that, and I just cognitively restructured it with them.
Yeah, it's using it at the same time, isn't it? If you're getting the drug to activate it, and then you're doing work with them to look at the other parts of it, it seems nonsensical. Of course, it's gonna work.
And just kind of what you're doing with your TMS is that
same thing. It's just activating the network, but in a different way. For sure. It's it's really interesting, and I hope the research that I've seen, although it has been little, looks to be kind of robust, and of course more work needs to be done, but I think it could definitely be a way that things progress a bit more in the future.
Well, hopefully, because I think things do need to progress one way or another.
Absolutely. As you say, it's about opening up the neural pathways a bit more and getting them, the networks that haven't been used, or as you say, for trauma, it's sometimes that amygdala is obviously overactive and firing a bit too much. But yeah, if you can activate all the networks that are a bit more quiet, will definitely help.
Definitely. Right, well, we just end it there, Isabel. So it was great chatting to you, and I think we should probably organise another one in the future.
Yeah,
I think we've got lots
I'd love
to talk
that.
about.
That's great.
If anybody listening to this has any questions about TMS, I will put Isabel's details in the bottom. Great, thank you.
Thank you very much.